I want to thank Peter and Anna for the invitation to participate in this session. A lot to get through in the short amount of time. No disclosures. I'll describe the impact of obesity on the outcomes of anti-reflux surgery, keeping in mind what we've talked about already, attempt to characterize how we go about evaluating the suspected failed fundo and in patients with obesity and discuss management strategy. Foremost, in my mind, when thinking about the failure of surgical therapy to begin with, is at least a word on the general efficacy of the thing we're discussing to begin with. And the fact of the matter is that anti-reflux surgery is highly effective for the treatment of GERD. We know that satisfactory results are reported in upwards of 90% in patients up to 5 years postoperatively. We do know, however, that somewhere between 10 to 25% of patients will redevelop symptoms, and that probably conservatively operative interventions undertaken somewhere between 3 to 6% of patients who redevelop symptoms. And so, but even in this context, in the redo cases, 70 to 80% of satisfaction and objective improvement is reported in redo cases. So I think as a general proposition, anti-reflux surgery is highly effective. Sometimes the factors that contribute to failure are categorized into patient-specific and technical elements. A number of these things have been addressed, but atypical symptoms, non-response to acid-suppressive therapy, certainly morbid obesity, and are factors that we talk about. But technical elements include not closing the crura properly, misplacing the wrap, making a wrap that's too tight or too loose, and not recognizing short esophagus or some technical problems that we talk about. So back to this question, does obesity impact the outcomes of anti-reflux surgery? And so this paper, Dr. Shada mentioned already, but it was a landmark study. I mean, this was, one of the first papers, probably the original one that in the literature started the conversation anyway, but it was pretty definitive. This is a highly respected group, about 224 patients with a good follow-up over 3 years on average. Overall, the recurrence rate was 11.6%. They defined recurrence by symptoms, responsive to acid suppressive meds, radiologic and pH studies, and were fairly unequivocal in suggesting that in the obese group, recurrence rate was around 31% compared to 4.5% in the normal weight group. And then there was this landmark study about a couple of years later from a highly respected group, twice as many patients. Overall failure rate was a little less, but this study showed that, in terms of anatomic failure, re-op, postoperative symptoms, there was no significant difference between the BMI groups. And so to try to, there's plenty of studies, and to try to make sense of all of this is a meta-analysis from just a couple of years ago that looked at 12 papers, and the primary outcome here that they were concerned about is symptomatic recurrence, and it was shown in this meta-analysis to favor the non-obese. And so we'll accept that there's controversy and that we don't have enough data even now, but for the purposes of the next few minutes, and since we're generally talking about patients with much higher BMI than most of these studies consider, that obesity does perhaps negatively impact the outcome of anti-reflux surgery. When we go about evaluating the failed fundo, the cause of failure is usually identified. In the overwhelming majority of the cases, it's usually anatomic or because of an erroneous indication to pursue primary surgery to begin with achalasia, probably the most common error in diagnosis. The anatomic failure, we'll talk about, a recurrent or a persistent hiatal hernia, slipped fundoplication, or one that was incorrectly constructed to begin with, and a disrupted fundoplication. The symptoms and indications for reoperation are going to be the same. It's recurrent reflux, regurgitation, and dysphagia. We go about collecting the history, studies, radiographs, detailed op notes, not simply because we're good surgeons, which hopefully we are, but the idea is that some of this begins to illuminate for us some of the potential causes of failure and perhaps more importantly, what the things that we encounter at reoperation. Most people would do an upper GI and an EGD and a repeat pH study, manometry, and certainly if there's nausea, vomiting is a significant component of the patient's symptoms, a gastric emptying study should be considered. This is a famous cartoon that demonstrates some of the failure patterns that you encounter, which with panel A showing disruption, and B slippage, and C transhiatal migration. But the question is, does the pattern of failure differ in obesity? And this is a study, it's a little old now, 2007, but this is a cohort of patients with BMI greater than 35 who had failed fundoplication, who were being converted to gastric bypass. And this group found a disruption RAP disruption rate of 46%, which is about twice as much as what you encounter in the remainder of the literature. And so the question is, does, for example, the higher intra-abdominal pressure that you encounter in obese patients predispose to RAP disruption, or is the RAP more difficult to create to begin with? And I believe those are rhetorical questions, and probably some elements of both of those things are true. What we do know for sure, however, is that the morbidity associated with reoperative anti-reflux surgery is something to take seriously. Everything from whether we're talking about injury to the esophagus or pulmonary infectious complications to leaks and things like this are more common. And so we do well to have a really a few guiding principles and things that lead us and move us in a certain direction. It's interesting to remember that somewhere around 10% of patients undergoing reoperative laparoscopic anti-reflux surgery will require yet another procedure. That's sobering. And so to me, the first question is, what risk factors for recurrence remain? And perhaps a more granular way of asking that question is, are the indications for bariatric surgery present? And if they are, i.e. a BMI of 35 with comorbidities or a BMI 40, then the answer is relatively straightforward. For me, it's a conversion to a root-wide gastric bypass. If the answer is no, i.e. class 1 obesity, again, we're talking about patients with BMI greater than 30 or higher here, convert to root-wide anatomy is something that ought to be considered very strongly as well. But we should recognize that redo laparoscopic anti-reflux surgery is an option here and is done fairly frequently. A few of the hang-ups in converting patients who don't, that's interesting. Yeah, can you help? Oops. I think that's next. Yeah, I can just advance it from here. Thanks. So a few of the sort of the difficulties that one runs into about converting patients who don't meet the traditional indications for bariatric surgery, i.e. BMI less than 35, are manifold. But one of them is, so and some of this is again going back to some of Amber's discussion earlier about patients who show up not wanting to have a morbid obesity procedure to begin with, and now you're talking to them about it. Number two are some of the insurance and coverage issues that come up, and then thirdly are you now going to be giving patients who have a BMI less than 35 excessive weight loss and nutritional issues and things like that? And the fact is that the literature does not bear that final point is not borne out in the literature, and I'll share some of that in a minute. I put this slide up mainly as a sort of, I really respect the study mainly because I think really it was the first study that looked at, people have been doing gastric bypass to treat reflux for a really long time, but I think this study was the first to actually look at the objective efficacy of the ability of gastric bypass to lower to sort of restore LES pressure to normal and to normalize Demeester scores and at least do it as well as a laparoscopic Nissen did, and a small study obviously, but that for me was the takeaway from this. So back to like some guiding principles. I think that the rationale for converting to a room-wide gastric bypass and makes the sort of the algorithm fairly straightforward in my mind, or I'll say are twofold. There are other reasons as well, but these are the two most compelling for me, is that it appears to be at least as effective as a Nissen, and the satisfactory rates of Nissen conversion to room-wide gastric bypass are similar to what you encounter actually in primary anti-reflux surgery with acceptable complication rates. And we don't have enough time to do this particular topic justice in the session, but the fact is that a lot of these papers actually include patients with BMI less than 30. And so it's just important to keep that in mind as well. Number two is that the idea that we would with a procedure address the obesity and comorbidities and improve cardiovascular morbidity and quality of life in a somewhat definitive manner is very highly compelling. So we've decided we're going to convert to some kind of fundoplication to a gastric bypass. It's fairly simple. The goals are going to be to take down the fundo completely, fix the hiatus, and convert to a room-wide gastric bypass. Very simple. But this is not always, but this is the sort of stuff that you encounter is obliterated tissue planes, obscured normal anatomy, gaping hiatus, twisted stomach, and foreign body, and all this sort of thing. And, if we're going to discuss pitfalls and perils, there are plenty, but just a few to move us forward is, be aware of the role that foreign body plays, so mesh and pledgets. Even if you didn't encounter this in the operative report, be prepared that this will add complexity and prepared to deal with this. The idea of completely taking down the fundoplication sounds easy. It serves a few purposes, and I think it avoids stapling of multiple layers of stomach, avoids creating an oversized pouch so that the operation can actually work in the first place in terms of reducing acid production, reducing the risk of marginal ulcer, which is the bane of the existence of the gastric bypass surgeon, and then certainly if we're talking about weight loss and weight regain, to reduce the risk of those problems as well. And I'll close by saying that this is as good a summary statement as any, that one gets better at this the more one does, just like anything else. And these things can get very, very complicated. This is probably not a good case to do just the 2 weeks after at your new institution on Monday morning, like 2 weeks post-fellowship training. And if you do, I think the idea of engaging somebody with more experience in the sort of the preoperative planning and decision-making, and certainly intraoperatively, these are not signs of weakness. Rather, I think they demonstrate wisdom and prudence. I'll stop there and thank you for listening.